Hey, welcome, Pahrump. I'm Dr. Michael Reiner, your host of the Independent Doctors of Pahrump, and tonight is a live show, and there will be a phone number that is broadcasted at the bottom, which will be 727-8750, and that's the number to call in if you have any questions about tonight's topic or any other topics that I've talked about in the past. And tonight we're going to I want to reiterate some things that I talked about previously. One was about the Class 2, Class 3 opioid and controlled medication issues, reiterating that if you are one of these patients that's affected by this new ruling that was handed down by Congress, that you should get in touch with your congressman and your senators to let them know if this impacts you in a negative way. I mean, I know it will impact you in a negative way when you got a prescription filled for a Schedule 3 product, an opioid. You could get that product refilled, and a lot of physicians were refilling those on a limited basis. The rule said, or the law said, 6 months, and they changed those to only no refills, which meant you had to make an appointment with your doctors, which overburdened the healthcare system that was already overburdened by the numerous increase in patients that we've seen in the last year due to Obamacare. So anyway, with that thought in mind, please reiterate that they're not going to change anything if you don't complain. I don't know if anybody else is complaining across the world. I mean, we may be the only place, but the squeakiest wheel does get the oil. On another note, haven't really heard anything new about new outbreaks of Ebola. It seems that maybe we do have some level on this. It's hard to say with the amount of workers that are going over there and coming back. I know the debate has been raging about whether people should be quarantined or not. I think it's really sad that people don't realize the importance of the disease that they're going to treat. I think it's great that they're going over there. I think that's a humane and certainly noble act to go to a country like that and put yourself in the way of a deadly bullet, and it must be a type of I don't know, I couldn't call it a death wish, but certainly life on the edge, and then to come back and be afflicted with that disease is a terrible way to be rewarded for those acts. But people go over there knowing what they're getting themselves into. Doing that, coming back here, and then assuming that they're better than everybody else and that they're not going to infect anybody else is a horrible statement of the elitism that these people may have. And to take it to the courts and do that other thing. I mean, the right thing to do, and this is what I'm getting at, the right thing to do is to self-quarantine yourself and to put yourself in a position not to infect other people. What a horrible thing to do to your fellow person, and especially the unsuspecting people. So that's my issue with this disease. I did talk a little bit about diabetes last time, and I'm going to spend a lot of the show talking about diabetes. And one of the things I want to bring back is a slide that we talked about earlier, which was diabetes type 1. I wanted to reissue or bring that one up so that I can lead into the topic of diabetes type 2 or the adult onset diabetes. Remember, type 1 is a juvenile onset. It really is not the same diabetes that we see in the adult population. It is more of an autoimmune disease, and what I mean by that is there's usually some virus, some issue that tends to cause us to start to lose our pancreatic beta cells. And insulin is made by cells in the pancreas, and they are just a very small amount of those. Let's see. We do have a caller. I think Ray, the flagman, is on. Can I hear Ray? Is he there?
Yes, Doc. Ray the Flagman. Nice to see you with your own show. It's good to see you on TV. And I noticed on your commercial, you're saying you're going to be on 46.4. You don't want to be on 46.4. You want to be on 46.1. 46.4 has an audio problem. You could tell Vern Van Winkle that's from the Flag Band. I can always have problems with 46.4. I got to ask you a question. I've been researching topical treatments for basal cell carcinoma. Can you tell me if there is something right now for basal cell carcinoma that they're using as far as helping people with that problem? And I'll listen. I'll hang up because it's hard to hear you over the phone, but I'm going to be watching on TV. Thank you very much. Congratulations on your new show.
All right, and I think there's a 7-second delay, but thank you for calling in, Ray. But yes, there is a topical treatment for. There's actually really two topical treatments, but the first one is they take you to the. There's actually 3 ways that they can treat basal cell carcinomas. Obviously, the first one is they usually do what they call a Mohs procedure, where they surgically excise it, and then they continue to check the margins to make sure that that has been eradicated. Very small ones, they will actually cryotherapy, and then hopefully they don't come back. And remember, basal cell carcinoma is not a metastatic disease, meaning it doesn't metastasize to a different area in your body. It does locally invade and can be quite disfiguring and ulcerating. And the problem with basal cells is sometimes whatever can cause a basal cell can also cause a squamous cell, and that is an invasive tumor. That is a tumor that can break the barriers of skin and proceed to other areas of the body and grow. With that being said, whatever cancer you have, you want to make sure that you do get rid of. One of the treatments is a topical called 5-fluorouracil, and they call it 5-FU, it basically is a local irritant and tissue destructive agent, and it can be applied to the skin when for maybe small residuals or things of that nature. It has also been very effective in that way. So with that being said, yes, there are topical treatments, and 5-fluorouracil being that one that I think you were speaking about. And whatever it is, make sure that you do seek reliable and frequent visits to the dermatologist to get that taken care of. I was hoping to have one of the local derms on the TV show that worked. Michael Roos is a PA with Tahiri's office, and I worked with him a little bit at the Pahrump Medical Center. I've been trying to get him on the show so we could talk about a lot of dermatologic subjects, because believe me, there are a lot, especially as and as our population ages, basal cell, squamous cell, and melanoma are very big issues in that thing. So I hope that helped you there, Ray. Anyway, going back to diabetes, remember type 1 is a juvenile or early onset diabetes, which does actually cause sometimes it can happen suddenly, sometimes it can happen more slowly, but it is important that as you are a youth that you do seek regular care and get your sugars checked. What we'll start to see is sometimes a slow process from age 13 on forward. You'll start to lose these beta cells, and then you get this 18 to 19-year-old who basically develops diabetic ketoacidosis, where they have no insulin in their body. And with no insulin, you cannot get sugar into your tissues, so your body breaks down fat, uses fat, your body fat, and breaks down protein to make sugar. The byproduct of that is being ketones. So as your sugar goes high, you dehydrate, and you make more sugar, but you can't get that sugar into your system, and you lose weight. Hence the Atkins diet. And Dr. Atkins was an endocrinologist, so he simulated that event in individuals by telling them just eat protein. If you eat no sugar whatsoever, you simulate the diabetic ketoacidosis model. That's why Atkins patients lose weight so fast, because they're breaking down all their muscle mass. But remember, your muscle mass is what burns your sugar on a daily basis. So, and you build up ketones, and ketones are byproduct of fat metabolism, and they make you feel sick, they make you feel tired, they cause muscle aches and abdominal pain and things of that nature. That's why if you're on the Atkins, your diet, you're only on it for a period of basically 2 weeks or something like that nature. And so again, juvenile early onset diabetes is an insulin dependent situation. You will be on insulin and you will have no ability to take oral medications. And hopefully, if you catch it early enough, there are some issues. I guess there's some viral treatments that are out there. Anti-autoimmune suppressors may be used. There may be a way to treat that at a young age, but the key is diagnosis. That means just because you feel good doesn't mean that you don't go to the doctor and get a regular checkup, at least a blood check. And if you don't want to go to the doctor to do that, then go to a health fair. They check your sugars all day long there. Just make sure you're somewhat fasting and understand what the normal parameters are for fasting blood sugars, so you know if you're in trouble. And I will go into that into type 2 diabetes. And we'll do that right after the break. So again, remember, type 1 diabetes, juvenile onset. Early type 2 is adult onset. And as we become older, we'll go into this model about being an adult and developing diabetes. It does start with weight gain. What I've talked about earlier in these shows is all about eating correctly, eating the right foods, and trying to prevent that weight gain that we do see. There's an overabundance of food, and if you are overweight enough, if you have a BMI over 30, you're very, very likely to develop diabetes, especially if you're in a genetic predisposition group. And what I mean by that is being a type 2, you basically, if you're a Filipino, if you're a Mestizo Indian or a Latin American or South American, Mexican national, you are very high risk for diabetes because of your genetic makeup. And that being said, you're more likely to develop diabetes, and so you have to be very, very careful. So we're going to come back from the break, and then hopefully I'll bring up some slides and we'll go into type 2 diabetes. And thank you for tuning in tonight.